welcome Dr. Thor Halfdonnarson.
Well, good morning, and thanks all for being here. Thanks to NCAN for putting this on. And just to let you know how important the NCAN work is, that probably every week I see someone in the clinic who has been around the internet and looking for valuable quality information on neuroendocrine tumors, and found it through NCAN. So there's a lot of quality content there that I would like you to explore if you have time. So my first talk is going to be on NET or neuroendocrine tumor basics and the top 5 topics you should ask your doctor about. And well, I'll sort of digress at times, so I will probably run a little over on this talk, but I will borrow from a second talk, which is not as long. So I just want to make sure that I don't rush through this, because there's a lot of stuff to cover. So again, thanks for the opportunity to present. Let's just dive into it. These are my disclosures. I do a lot of research and consulting for different entities. So these are the top issues that you should discuss with your team. If you or someone you know was diagnosed with a neuroendocrine tumor, then these are reasonable questions to ask. So obviously, always you ask, do we really know what we're dealing with? Have we confirmed the diagnosis? Have we done all the needed tests? And then I wanted to clear some of the confusing terminology of NETs. And then, do I need to see a NET expert? We're even going to talk about what is a NET expert anyway. Do I have to start therapy? We'll cover all of this in the talk. And then some of the side effects of therapy, and then finally touch on clinical trials. So let's just dive into it. So the first question to your doctor would be, do we really know what we're dealing with? Someone just got diagnosed with what seems like cancer, either localized or metastatic, and there's a lot of stuff we need to know. And so let's go through this is sort of a mental checklist of mine that I think works well for you as well. So when I see someone in my clinic for the first time, someone I've never seen before, so gone through the chart, and I always go through, for those of you who have met me in clinic, I always go through everything again in the clinic. Kind of painful. You think I would know everything when I walk in there, and having read your chart, I read your chart, but I just want to hear it from you, how things unfolded, in what sequence, because that helps me paint a better picture of what has happened, what's been done in the past, what do we need to do in the future. So and these are questions I ask myself. So did I get the diagnosis right? So I may go home thinking, I'm not sure if I got this right. So and sometimes I'll say it might keep me up at night. So has this been reviewed by a pathologist I trust? Do I need to have this run by someone else? And sometimes the pathologists actually do this themselves. So the pathologists look at the biopsies and say, well, I'm not sure about this. Let's run this by my colleague in the next office. And they take it to the colleague in the third office. And this is actually how things work at larger centers. And we'll get back to that later. So then, have I done the necessary workup? Did I order all the appropriate imaging? And there's a lot of imaging. We'll talk about that. Have I staged this? Do we know what stage this is? Do I have all the labs I need, including tumor markers? And we may or may not talk about tumor markers. I won't cover tumor markers much here, but I'm certainly happy to do that in questions. And then, what is the intent of therapy? This is actually really important. So are we trying to cure someone? Is someone with localized disease, we're going to try to take it out and be done? Or are we going to control the tumor and make a person live longer, feel better, and that sort of stuff, maintain the quality of life? And then most importantly, and we can't really get to this question until we've covered the other 3, is that what are the goals, the patient's goals, wishes, expectations? And this is very crucial, and we have to be honest, there are situations where we know that with the current methods we have, we can't really make this problem go away. It's an incurable advanced cancer. But there's a lot of stuff we can do. And be just honest, sometimes we just don't know. So I get asked a lot, so how long do I have to live? And it's not like I'm trying to avoid the question. A lot of times I just don't know. Neuroendocrine tumors are just so hard to predict. Okay, so let's go into the nomenclature. I often think of Humpty Dumpty when he said, when I use a word, it means just what I choose it to mean, neither more or less. So this, to me, sometimes feels like the nomenclature or naming of neuroendocrine tumors. There are all of these names, carcinoid, islet cell, neuroendocrine, carcinoma tumor, what have you. And the question is really whether you can make words mean so many different things. And we'll try to clear that confusion. So NETs, NECs, and NENs. So NETs is what we all know about, neuroendocrine tumor, but they are not the same as NECs. So NENs, which is probably the best term for this, is neuroendocrine neoplasm. NET is a neuroendocrine tumor, NEC is a neuroendocrine carcinoma, and they'll go through what this all means. So a neoplasm, or a tumor, is essentially just a mass, an abnormal mass of tissue that happens when the cells are growing and not dying as they should. And the tumor and neoplasm is essentially the same, although the neoplasm in the NET world means a little bit different. A carcinoma, however, is the same sort of clump of abnormal tumor cells that no longer is respecting the boundaries around it, so it starts growing into things and sending off metastases, like little cells start traveling around the body and setting up shop in different other organs like the liver, lungs, bones. So that would be a carcinoma. So NENs is the most inclusive term. It's just not as easy to say as NETs, so I'm going to stick with NETs for now, but I just wanted to put it out there. So NENs is really the term that captures them all. So you have the well-differentiated neuroendocrine tumors. They come in 3 different grades, grade 1, grade 2, and grade 3. I'll talk more about that. And then you have the poorly differentiated neuroendocrine carcinomas. They only come in 1 grade, grade 3. But all of them are NENs, NECs, and NETs are NENs. So it's just the sort of more inclusive term. So these are cancers that can arise anywhere in the body. So I've seen them arise in pretty much any organ, any location of the body. Most commonly in the small bowel or the small intestines, lungs, pancreas, stomach, rectum, but we can see them in the larynx, in the voice box. We can see them in all sorts of different, in the ovaries, uterus. Name an organ. I think I've seen it arise in pretty much any organ in the body. And they are extremely heterogeneous in the sense that they're almost as if no two NETs or NET patients are the same. They all seem to present in their own way with their own symptoms. So which makes it, I think, a little different from many other cancers like colon cancer and breast cancer. I'm not saying those are simple cancers, but they in some ways are a little bit more predictable. And we have all these what's called neuroendocrine tumor cells that are sort of dispersed throughout the body. We can find them, and these are normal cells. We all have them. It's just something that happens that makes them go bad. And now they start dividing and not dying when they should not be dividing and actually should be dying. So that's what makes them into cancers. Okay, so how do we diagnose this? I always say it's a team effort, so you really need a good team. And really, I'm not going to knock other team members, but really the pathologist is an experienced pathologist is really crucial. And it's a tricky diagnosis. You look at it in the microscope, you have to do some additional tests and stains and look at it. And they just sometimes look like other cancers. And we've all seen this in the clinic. Someone comes in with, years ago, I saw someone came in with what's called bile duct cancer. Turned out to be a neuroendocrine tumor. We've seen people we thought were neuroendocrine tumors, turned out to be something else. And this is where it really helps to go back, show it to other pathologists in the office, and really to make sure that we have this right. Even the best pathologist can sometimes be puzzled by this. And then we have the radiology and nuclear medicine, and really experience matters. I'd say experience probably in most cases matters more than equipment. And so you can buy the fanciest scanner on the planet, but if you don't know how to use it, it's no good. And then we have all of the other specialties, gastroenterology, which we rely heavily on to get samples, to do some of our treatments, clinical chemistry that does all of our tumor markers and stuff, lung medicine or pulmonary medicine, surgery, endocrinology, and the list goes on and on and on, and there are more that they didn't list there. So the pathologist, going back to the pathology, so really critical. So if we've looked at this, well, we haven't really looked at this in Mayo, but others have in Europe, and about 20% of the initial pathology read at home at the initial diagnosis in the local cancer center is actually incorrect. And so most of the time, the differences are very subtle and don't matter that much, but sometimes they are just completely way off. And so that is why we need these biopsies to be reviewed by someone who does this day in, day out. And even the expert pathologist may struggle with this. So let's talk about tumor grade and differentiation. You'll hear this all the time: grade 1, grade 2, grade 3, well and poorly differentiated. What does all of this mean? So the tumor grade is really just a system to predict how fast cancers will grow. So there are several different systems, but the one we use in neuroendocrine tumors is called KSH7. Sometimes it's called MIB1. So it's essentially like a tissue stain. So you just have little thin section of the tumor. You cut it really thin. You put it in a little glass slide, and you slap some stain on it, and then we wash the stain off. And if the stain sticks, this KSH67, it sticks to tumor cells that are actually growing. So then we look at the whole number of cells. We count the dots that are actually growing, and then we count those that are not staining positive, and I'll show you a picture, and then we come up with a tumor grade. And the tumor grade really predicts the aggressiveness and the tumor growth rate of the cancer, and really is the strongest predictor of long-term outcomes, including life expectancy. And it's the pathologist's job to do this. We actually do a lot of this with not with AI. We do what's called digital image capture. So we stain the slides, we run them through these machines. The machines actually counts thousands of cells and spits out a number that's incredibly precise, much faster than the human eye, and definitely preferred if you have it. So this is how it looks in practice. So so you can see on the left-hand side, that's grade 1. We see all of those like the blue dots, and then we see a few brown dots. So those are the cells that are actively dividing. The others are just in a resting phase, just sitting there chilling out and not growing. But the brown ones are the ones actually that are growing. We count them, and if it's less than 3% of the total number of cells, it's called a grade 1. If it's between 3 and 20, that's called a grade 2. If it's more than 20, you see on the right-hand side, a lot of these brown dots, that would be grade 3. But here is the problem. So there has to be a difference between 21 and 99. And that's actually where the differentiation comes in. So if you have someone who has a KS7 of 21, it's a grade 3. You have someone with a KS7 of 99, it's also a grade 3. But these are totally different cancers. So the grading system alone will not get us the information we need. That's where we need the differentiation. This is sometimes the way I look at the grading. So grade 1, slow growing, can be incredibly slow growing. And then grade 3 would be something that's fast moving. But some of the grade 3s are just surprisingly slow. And I have multiple patients with grade 3 tumors where I expected them to really grow fast, and they just are not. So the grade alone is not going to tell you all about the growth rate. Well, the differentiation helps a little bit. So what is differentiation? This essentially means how much do the cancer cells look like the cells we think they started from, so the normal counterparts of the cancer cell. So this is pretty challenging because here we actually need human eye. This is where AI has not taken over yet. And so this needs a pathologist who's been seeing hundreds, if not thousands of these, and they look at it and they sort of scroll back and forth and zoom in and zoom out, and then they decide, they make a call just based on past experiences. There's poorly differentiated versus well-differentiated. So the poorly differentiated tumors are typically, they look slow, like they're up to nothing bad, and the aggressive, poorly differentiated tumors tend to be more aggressive, and you can just look, you can see it on the slides, see it on the appearance of the cells, the different sizes and shapes, and like my wife's actually a pathologist, and she doesn't practice anymore, but she says that these are the cells that you don't want to meet in a dark alley at night, and so they just look, but the thing is that sometimes they can look really, really angry and ugly and still not behave badly. So the tumor differentiation doesn't tell you everything either, and this is just to hammer home the point that the poorly differentiated tumors are all grade 3, but not all grade 3 tumors are poorly differentiated. But really the most important thing is to observe over time. So we can have, and I've seen this dozens of times, and we'll see this in the future. We have 2 patients who have exactly the same tumor, looks exactly the same in the microscope, has exactly the same KS7, started in the same organ, and one is moving really fast, one is moving really slow, and we just don't know why that is. So let's move on to imaging. So imaging is another team activity, so we need expert radiologists and nuclear medicine specialists. And but as I said, there's more to imaging than fancy machines. So you have to have a good tech. So if you don't have well-trained technicians to run the machines, these are the people who put you in the machine, put the timers on for the contrast and everything. If they don't know what they're doing, we're not going to get great imaging. So 3 types of scans in the clinic. The CT is still what I rely on. Fast, reproducible, great imaging, but it has to be done correct with at least 2 what's called 2 contrast phases. So venous contrast and arterial contrast. So the arterial contrast, the moment after the contrast is injected, we run you through the scanner once. And then we wait like 70 to 90 seconds, and then we run you through the scanner again, and we can do up to 3 of these phases, so arterial, pancreatic, and venous. The pancreatic one we don't typically need for routine. It adds to the time of the scanner, adds to the radiation a little bit. So this is the crucial part, and I'll show you in a moment why this is crucial. So let's say if you slip on the ice shoveling snow in Minnesota and you go to the emergency room and they run you through the CT because they want to look at internal injuries, you're not going to get a monophasic CT. So you're only going to get the venous phase. You can hide a lot of neuroendocrine tumors in that scan without knowing. And then we have the MRI. MRIs are slow, painful, claustrophobic, but give absolutely crisp and beautiful images, especially of the liver. There's nothing that beats a good MRI for the liver, nothing. And then we have the PET scans, which are incredibly helpful, but also overused and incorrectly used a lot. So if you're measuring tumor growth, I would much rather have a good CT or a good MRI than a PET scan, and because you can't really measure size of a PET, but you can measure or find out where the tumors are in unexpected places, like in the bones. Let's say if you have someone who has bone tumors, it's almost impossible to get a good view of the bone tumors with other than a PET. So you have all of these 3 types of scanners, CTs, MRIs, and the PET scan, and they are all absolutely crucial, but you just have to know when to use them and to get the best information. So I wanted to show you this. So on the left, the colorful images on the left are PET images. It's actually from one of our PET CT scanners. You can see the red dots and the big green thing there is the liver. I don't think I have a pointer on this. I do have a pointer. So this is the spleen. Always lights up like that. That's normal. Mine would light up like that too. And then you can see those little red dots in the liver. These are the tumors. So then these are all done on the same day. So these are literally done within minutes of each other. So you can see, and this is a venous phase. You can see those little darker spots here. So those are tumors, and they correspond to the lighter spots there. But look at that. This one in the arterial phase does not show up here. This one does not show up here. So if you only do venous phase imaging, you might actually miss all of the tumor. And even the arterial phase is not perfect. So, and then the other thing with PET scans, PETs are absolutely fantastic. I love having access to a good PET. But here we have someone with a pancreatic neuroendocrine tumor. So this is the left kidney, that's the right kidney. This shouldn't be there. This is a neuroendocrine tumor. And it looks pretty big, doesn't it? And well, let's take a look at the MRI with it. Here's the pancreas, that's the head of the pancreas. The little white dot, that is the tumor. So the tumor on the PET scan looks about 4 times larger than the actual tumor does. And that's because the PET is a little bit like looking at the light bulb. So we gave you something that sticks to the tumors, it glows in the dark. It's like an LED, that's a big halo around it. But when you turn off the electricity, there's just a tiny little light bulb. So this is why we cannot use PET scans to measure tumor size. Plus, we wouldn't even be, it's just hard to do. So this is one of my patients. This patient was completely without symptoms, a low-grade tumor, 2019. You can see we're looking at these little dots are in the bones, and then a few years later we saw a lot more in the bones. This is a PET scan, what's called a dotatate or somatostatin receptor PET. This is not the metabolic PET. This person was entirely asymptomatic, and these tumors just were building up slowly in the bones, and we decided to do radioligand therapy with PRT, and to last I knew, this patient was doing really well. And so we definitely we would never have seen all of these bone spots had we not done the PET. So it just goes to show that you do need the PET at times. I'm not knocking PET, saying you shouldn't be using it, but we just have to know when to use it. Okay, I just wanted to show you this because these are some like images from our PET MRI scanner that I think are interesting. So for small bowel neuron tumors, sometimes metastasize to the breast. So this would be in the left breast. Sometimes these patients are incorrectly thought to have breast cancer. And I see about 1 to 2 women a year who presented with a breast mass, thought to have a breast cancer, had a biopsy that was a neuroendocrine tumor, and it's almost always from the small bowel. And brain tumors are thankfully very rare in well-differentiated neuroendocrine tumors, but are fairly common in poorly differentiated neuroendocrine carcinomas. This is here a cut through the level of the eyes. We can see the left eye here, actually right eye, left eye, and these dots are behind the eye, so these are called orbital metastases. These we see in small bowel and sometimes in pancreatic neuroendocrine tumors fairly commonly. A lot of times they don't cause any problem. Sometimes they can get in the way of the movements of the eyes, and we sometimes have to radiate them, and that typically takes care of that for good, so without damaging the eye. And then this is what we're picking up a lot. So this is cut through the heart. You can see on the lungs, you can see a couple of spots in the lungs. You can see a couple of, one spot in the heart. So these are heart metastases from small bowel neuroendocrine tumors. We're finding these in about 5% of our patients now, and they never cause problem. They have never, ever seen one of these cause problem. They just sit there and scare us and scare the radiologists, and I just have to explain to people that, yes, we do see them, but they almost never seem to grow. Once you have 1 or 2 of them, you rarely seem to get more of them. So it is, and we've reported on this 3 times now. We looked at 2,000 PET scans at Mayo and found this in about 3 or 4%. Then we've just completed our work to look to see if there were any heart problems. Nope, not one patient had any problems from this. Okay, so let's talk about staging. Who decides on the stage? Well, I do, and so after looking at all the available information, including the pathology reports and the scans, so sometimes we need the endoscopy report, sometimes we need some additional reports looking at the surgery notes and things like that. But this is sort of an explanation of the tumor stage. So stage 1 is localized, stage 2 is still localized, but just bigger. Stage 3 is now starting to get into the lymph nodes. Stage 4, it's traveled to different parts of the body. So this is another way to show that. So stage 1 and 2, limited to the organ, but of different sizes. And stage 3 would now be into the lymph nodes outside of the organ. This is actually from colon cancer, so we rarely see well-differentiated neuroendocrine tumors in the colon. We see them in the rectum quite a bit, but not in the colon. And so we can see those lymph nodes here. And then stage 4 is if it's gone to the liver or to the lungs or bones. And then the next question is a functional malignancy. Does this tumor produce hormones that cause symptoms? A lot of neuroendocrine tumors produce hormones, sometimes in small quantities. And for example, following a person with a pancreatic neuroendocrine tumor, it always has elevated levels of glucagon, but never had any symptoms of that. So we just measure it and use it as a marker, but it's never causing any symptoms. If the tumor produces hormones, then you should that cause symptoms, then we call it a functional tumor. Just 2 weeks ago, 3-4 weeks ago maybe, I saw a person with a neuroendocrine tumor who has had it for a long time. It's in the pancreas, it hasn't grown. And then as the visit was ending, she told me, yeah, by the way, I actually had a CT scan for something different I needed, and they asked me to be fasting, and then I was all sweaty in the scanner. They measured my glucose, it was 39. And then I told her, get a glucometer, and if this happens again, check this out. So she has now 4 episodes of really profound low blood sugars from a previously non-functional pancreatic tumor that all of a sudden decided, now I'm going to make insulin. And now this is what's called an insulinoma, and we'll hear more about that when Dr. Dillon talks in the afternoon about where the endocrinologists come in. So sometimes these tumors start as non-functional, become functional, and start producing hormones. Sometimes they start with hormones and then say, no, I'm done with hormones. I don't want to do that anymore. That's old. And let's stop producing hormones, and they become non-functional. And the poorly differentiated neuroendocrine carcinomas rarely do functional syndromes. So let's move on. So I know we're only at section 2, but all of the other sections are much shorter. So do I need to see a NET expert? So that's a good question. I would ask again, what is a NET expert? Am I a NET expert? So, and if so, who determines if I'm a NET expert? And so there is no standard definition. I say someone who sees a lot of NETs or NENs should be a NET expert. But what is a lot? Is that like 5, 10, 50, 400? So we just don't know. So we really don't have a good explanation. I would say someone who sees patients with neuroendocrine tumors several times, I'd say ideally a few times a week or at least several times a month, would be somewhat of a NET expert. Someone who does a lot of neuroendocrine tumor research. Is maybe sort of like a true expert. If you're doing research, you've been doing this for more than 10 or 20 years, and you have more than whatever number of papers, yeah, you could probably call yourself an expert. But we don't have a definition for it. And for a NET expert center, we don't have a definition in the U.S. The Europeans are ahead of us with this. They have a definition of centers of excellence, and the University of Iowa is the only one in the country that has that designation, but they are not offering it to any more U.S. centers now. So even if we wanted to get a European certificate of expert center at Mayo, we can't get it. And so we're talking about whether we should do that in the U.S. or not. So, and as I said before, NEN medicine or NET medicine is complex, it's a multidisciplinary, and you need to have a good team. If you have a great team, but a pathologist who's just really lousy, then your team is not good. If you have a medical oncologist who just doesn't know about this, your team is not that good. And so you're only as good as your weakest link. And how do you find a NET expert center? You talk to NCAN, you talk to colleagues, you talk to other patients and their families, and you just sort of ask around. That's really the only thing we could do now. There will hopefully be some lists of expert centers. So why do you want to see a NET expert? Well, these are uncommon tumors, and they don't have a whole lot of data. It's not like breast cancer and colon cancer, where we have multiple trials with thousands and thousands of patients. We can say, for this particular situation, we do that. And for neuroendocrine tumors, we just don't have that amount of data yet. So a lot of it is based on what we've done in the past and what has worked with others when we talk to our colleagues and such. And then we, the NET experts, may have access to services not available to community oncologists, like the pathologists. We talked about that, specialist surgery, other specialties. And then, importantly, if you see a NET expert, it doesn't mean that you need to see a NET expert every time. I prefer collaborating with community oncology. I think actually that's the best mix. Most of the things are done at home, but then we are available when there are major decision points. Let's say tumor is growing, you're on therapy, the tumor is growing, we need to do something different. That's where I think the NET expert is most helpful. So, ask your doctor these questions. So what's your experience managing patients with NETs? I know this sounds a little, I wouldn't say rude, but it's you have the disease. You have all the right to ask about this. And even the busiest oncologists just may not have a lot of experience with this, but some of them are actually surprisingly good at it in the community, and because they've just seen them through the years. Are you sure we have the correct diagnosis? Going back to the questions I was asking myself in the beginning, are more tests needed? Should I seek out an expert in management of NENs? So this is a reasonable question to ask your oncologist. So they actually may say, and sometimes they're relieved that you asked them and say that, yeah, I actually think you should. And so this is a very important question to ask. And then if I get an expert opinion, are you willing to work with that person? And if the answer is no, get another oncologist. Well, thankfully, the answer is almost never no. Honestly, I can't even think of a situation where a primary oncologist told a patient, you should not do this. I can't recall it, and which is great. And in Minnesota and in the upper Midwest, Wisconsin, the Dakotas, we're just fortunate to have a lot of really superb community oncology. So our role at the center is just to make sure the plan is good, we have the diagnosis correct, and we talked about the changes in the treatment plan in up to a quarter of patients, and then be available when really needed. And So one problem there is that sometimes if things happen quickly, we can't get you in like 3 or 4 weeks. And that's something that we as institutions need to work on. And we're trying to solve that problem. And then let's say if you want to go on a clinical trial, you've been talking to family members, and now someone asks, "Oh, did you talk about the clinical trial?" Well, that's a good reason to come see us. We have a lot of trials at Mayo. We have probably 5 or 6 or 7 net trials now, and more coming. So what is a tumor board? So you hear this a lot. So tumor board is really a room like this. It can be virtual or it can be real, and with lots of different experts in different specialties, just getting together, brainstorming about your case. So when I bring someone to tumor board, I put the case up for discussion, I present your case to a bunch of surgeons, pathologists, radiologists, and who is in that room, virtual at Mayo, it's all virtual. And we do this regularly, and we present our challenging cases there. And then we just brainstorm. Oops, is that... I think I asked for a little extra time. Okay, I'm not going to get zapped or anything. Okay. And okay, so yeah, and I walk into the tumor board, and I think like this on Thursday morning, I presented the case at tumor board, and think, oh yeah, the greatest plan ever. No one is going to challenge me on this plan, and then I walk out with a totally different plan, and that's just because the surgeon started looking at things a little differently, and one of the surgeons, well, actually, this I think we can do something for. So now I pick up the phone, call the patient, say, actually, what I told you on Monday is actually not what we should be doing. And this is the way tumor board should work. So you go in there with your best possible knowledge, think you have the best plan, and then you present it to your group of experts, and then together you come up with a good plan. And this can actually translate to fewer visits. So instead of you seeing 3 different surgeons and the gastroenterologist and the lung doctor, you can actually just do it all in tumor board. You see me, and then I call you, or I have a video visit with you afterwards, and we talk about the plan. So that's, I think, the best use of tumor board. Some present all of their cases at tumor board. That's perfectly fine too. If you see 500 new cases of, as we do at Mayo, there's just no way we can present every single case at the tumor board. So, so it's hard. And so let's briefly talk about the problem with multiple expert opinions. So this, not too long ago, I saw someone with a really challenging situation. And I was the 5th sort of expert in neuroendocrine oncology, person had been to a lot of different major academic centers. And they all had, I think, really good advice, but they were not always the same. So that just goes to show that the decisions you make for your patients, there may be more than one way to a right treatment. So this person may have this idea about doing this, which is a great idea. This person has a totally different idea, which is also a great idea. So a lot of this is based on prior experience, and as Will Rogers said, good judgment comes from experience, and a lot of that comes from bad judgment. So all of us who've been doing this for a long time, we've sort of seen what works. We've learned from our mistakes and learned from clinical trials. So just be aware, if you go seek a lot of expert opinions, you're going to get sometimes divergent recommendations, which can cause anxiety, but it doesn't mean that the first person you saw was wrong. It just means that they have a different approach. But it can also delay starting treatment. So that gets to the point, do we need to start treatment right now? And then not always. So many early stage, like stomach, pancreatic, small bowel tumors, even if metastatic, can be observed. I saw 2 patients in this already this month with metastatic disease. We have no idea how long it's been there. We just found it this month. And both of them said, I'm in no hurry to start. So that's totally fine. Just bring them back in a month or 2 or 3, depending on sort of the comfort level. Scan again, see if anything has changed. I have some people I've been following for years with metastatic disease who have never seen any treatment at all. And they have one person who has metastatic pancreatic neurotumor for now 8 years. We've twice done selective ablation of liver metastases. Otherwise, we just waited. The person's never seen any drug. And this could easily go on for some more years. So you just have to be really careful. Sometimes just sort of doing nothing is a good thing. So I sometimes think of this as like running a marathon because we're in this for the long run, and I look at the net therapy as a small deck of cards, small but growing deck of cards. Some cards are really good cards, others are okay cards, and so you have to play them carefully. And sometimes not doing anything is reasonable. That's actually one of our cards, and so waiting until things are growing and then play a card is good. It's not a guarantee that if you play your best card up front, you're going to get the best long-term results. So that's also where tumor board comes in. So play your cards wisely. So number 4, side effects of therapy. We won't go much into this because we're going to have a whole sections on different therapies. But it's just important to talk about this. Talk about the goals for different situations. What are you trying to get out of the treatment? Are we trying to extend life? Are we trying to alleviate symptoms? Is there a tumor mass that's pushing on something, causing pain? Or is there hormone production? We just have to talk about all of these. And then what works for you may not work for the next person in my clinic, even though they seem to have the same type of tumor. So, and what is reasonable and acceptable to you may not be reasonable and acceptable or even affordable to someone else. So should be unhurried, and a lot of times at the end of the first visit, we just, after like an hour, we say, well, we've talked a lot and we haven't come to a conclusion. Let's sleep on this. Let's talk again in 2 weeks, and just let you talk with your family members and friends, and then we just revisit this. But if it's an aggressive tumor, we may not have the luxury of doing that. And then you got to balance the risks against the benefits. All treatments have some risks. Some have higher upfront risks, like big surgery in the hospital for a few days, and you're going to feel a little sore afterwards, and some recovery time. But it may be worth it for in the long run. And sometimes the higher risk can be very acceptable. Let's say someone has a symptomatic neuroendocrine tumor that is causing a lot of symptoms, and we're trying to cure this. Well, big surgery may actually make a lot of sense. And this is, so myself and my team, we should really be able to talk to you about all those risks and benefits of treatment. So how do we sequence things? We don't really know. So there are so many options we have and more options coming. And we know surprisingly little about in what sequence should we play our cards. So we're getting a little bit more information there. But as I said, start with if it's a low risk, slow growing, few symptoms, start with the least toxic, most convenient treatment. That's always my take on it. And then look at other illnesses, comorbidities. Let's say someone who has diabetes might not tolerate everolimus well. Someone who has really high blood pressure might not tolerate sunitinib or cabozantinib well. So we have to talk about that. And then financial toxicity is very real. So let's sometimes do this little exercise here. So so these are the treatment types we have. So we have chemotherapy, PRT, surgery, liver-directed therapy, targeted therapy. And let's say each and every one of these contributes like this much to your life expectancy. And if we put it all together, are we going to get something like this? That's like the sum of these individual parts. Or do we get something like that if we sort of play this wisely? And I think we're actually down here. If you look at the survival contribution of each treatment type, and then you look at the life expectancy of the patient, the life expectancy is often much, much, much longer than you would have expected just by adding up the survival advantages of individual treatments. So this actually goes to show that you have to sort of play your cards carefully when you really need to. And your mileage might vary, as I say. So, and should I consider participating in a clinical trial? Always consider it. It may not be the right thing for you, but consider it. Go into the clinics, especially if the tumors are growing. Ask, do you have anything exciting and new for me? Any clinical trials? Right now, we have 2 clinical trials with alpha particles at Mayo, both for previously untreated patients and previously treated patients. We're going to get a lot of exciting studies coming up soon. So always ask about that. So that brings me to the end of the talk. I promised I would ultimately stop. So thanks to all of you, the families, caregivers, advocacy groups. We wouldn't be able to do it without them. And then all of the non-providers out there. So we're trying to come up with better and more tolerable treatments. So that is it for me. Thank you very much.